Patient, Mrs. Alvarez, 73-year-old female background. Severe COPD, gold stage 3, home O2 at 2 liters per minute. 40-pack years smoking history, quit 5 years ago. Type 2 diabetes, hypertension. Presenting TD, I've been coughing up green phlegm for 3 days. I can't walk to the bathroom without gasping, even with oxygen. Clinical findings. Vitals. Temp 38.4 degrees Celsius, 101.1 degrees Fahrenheit, HR 112, RR 28, SpO2 88% on 4-LNC, BP 154 to 90. Physical. Barrel chest, tachypneic, using accessory muscles. Auscultation. Breath sounds right base, coarse crackles mid-right lung. Labs. WBC 14.5K/L, BNP 120 PG/mL, normal.
This is an AB erect chest X-ray of a adult. There are no patient identifiable data on the X-ray. I would like to confirm the patient's name and the date of birth and the date and the time of the X-ray was performed before making any further assessment. The patient is slightly rotated to the right, and the X-ray is underpenetrated. It is otherwise a technically adequate examination with a satisfactory inspiratory achievement and no areas cut off. The most striking abnormality is increased density in the right lower zone. This is the most notable behind the right side of the cardiac shadow. The medial aspect of the right hemidiaphragm is obscured, but the right heart border is clear, indicating there is a right lower lobe consolidation. Elsewhere in the lungs, there are coarsened lung markings in keeping with the COPD, but no other areas of consolidation, and no lobar collapse or pulmonary massive nodules. Allowing for the rotation, the trachea, mediastinal and cardiac contours, and the hilum was unremarkable. The costophrenic angle are sharp with no evidence of pleural effusion. There is no free subdiaphragmatic gas. No skeletal or soft tissue abnormality are noted. So in summary, this chest X-ray shows the right lower lobe consolidation with background changes of the COPD. Given the clinical findings, these changes are consistent with right lower lobe pneumonia. A follow-up chest X-ray in 4 to 6 weeks after appropriate antibiotics treatment should be considered to ensure the resolution of the pneumonia.
What does Mrs. Alvarez's chest X-ray most likely indicate? A. Acute pulmonary edema. B. Right lower lobe pneumonia. C. Tension pneumothorax. D. COPD exacerbation only. Answer B. Consolidation with air bronchograms is classic for bacterial pneumonia. Hyperinflation reflects COPD, but doesn't explain fever/consolidation. The crackles in Mrs. Alvarez's right lung correlate with which X-ray finding? A. Hyperinflation. B. Consolidation. C. Blunted costophrenic angle. D. Flattened diaphragm. Answer B. Crackles plus consolidation implies fluid/pus in alveoli pneumonia. Hyperinflation causes diminished breath sounds globally. Which X-ray finding requires immediate intervention in a COPD patient? A. Hyperinflated lungs. B. Consolidation with air bronchogram. C. Subcutaneous emphysema. D. Mediastinal shift away from affected lung. Which finding on the initial X-ray requires immediate nursing intervention? A. Hyperinflated lungs. B. Right lower lobe consolidation. C. Blunted costophrenic angle, pleural effusion. D. Air bronchograms. Answer C. A blunted costophrenic angle indicates a pleural effusion, which could become an empyema, which means pus in pleural space, if infected. Nursing actions should include monitoring for increased diffusion via dullness to percussion, tracheal deviation, preparing for thoracentesis if enlarging. The nurse notes the blunted costophrenic angle on X-ray. What action is critical? A. Monitor for tracheal deviation. B. Prepare for thoracentesis if effusion enlarges. C. Administer 4-furosemide. D. Increase oxygen to 6 liters per minute. Answer A. A blunted angle indicates pleural effusion. If it rapidly enlarges, e.g. empyema, it can cause tracheal deviation by tension effusion. Furosemide is contraindicated here, not HF. Large pleural effusion has empyema/tamponade risk. Nursing action should include to assess tracheal position, prepare for thoracentesis. Which X-ray finding requires immediate intervention in a COPD patient? A. Hyperinflated lungs. B. Consolidation with air bronchogram. C. Subcutaneous emphysema. D. Mediastinal shift away from affected lung. Answer D. Mediastinal shift suggests tension pneumothorax, which is a surgical emergency, a deadly complication in COPD possibly due to ruptured pleb. Requires needle decompression stat. What teaching is most critical before discharge? A. Complete all antibiotics even if symptoms improve. B. Use your rescue inhaler every 4 hours. C. Restrict fluids to 1L/day. D. Stop smoking immediately. Answer A. Incomplete antibiotics leads to relapse/antibiotic resistance. Fluid restriction is for heart failure, not pneumonia/COPD. The provider orders a repeat chest X-ray in 4 to 6 weeks. What is the primary rationale for this follow-up? A. Assess for resolution of pneumonic changes. B. Monitor progression of COPD. C. Evaluate for new pleural effusion. D. Rule out lung malignancy. Answer A. Consolidation should resolve with antibiotics. Persistence suggests complications, e.g. abscess, malignancy, or misdiagnosis.
Code sparse mnemonic for COPD complications. Consolidations indicates pneumonia. Obstruction, mucus plugging. Lung collapse, pneumothorax. Diaphragm flattening, hyperinflation. Septal lines, earlier pulmonary edema. Pleural effusion, air trapping, subcutaneous air.
X-ray essentials for nurses. 1. Can't miss findings in COPD patients. X-ray finding. Clinical significance. Nursing action. Mediastinal shift. Tension pneumothorax. Surgical emergency. Call provider. Prepare for decompression. Large pleural effusion. Empyema/tamponade risk. Assess tracheal position. Prepare for thoracentesis. Subcutaneous air. Possible pneumothorax. Stat portable X-ray. Monitor for tension. 2. Early pneumonia recognition. Consolidation equals whiteout with air bronchograms, like tree branches. Colpasis. COPD masks pneumonia severity. Hyperlucency can hide infiltrates. 3. Effusion versus pneumonia. Effusion. Meniscus sign. Fluid layers. Blunted angle gravity dependent. Pneumonia. Lobar pattern. Air bronchograms not gravity dependent.